And we're live from the living room as Doug eyes up the matchday spread. He's reaching for the buffalo wing. Perfect! Hang on, what's this? Oh, he's gone for a can of Pepsi too! Incredible! What a finish! Sensational combination! Look at the delight on his face. There's no doubt about it. It just tastes better. Match days deserve Pepsi. Food deserves Pepsi. Grab a pack of Pepsi Zero Sugar for today's match. It's poetry in motion.
This is going to be an extremely busy month. I have to watch 104 soccer games, follow the pregame, the postgame, yell useless opinions at the TV. It's a lot. So I knew that when it comes to screening for colon cancer, the choice was clear. The Cologuard Plus test. It can be used at home and can only take 15 minutes, so I can do it during halftime and not miss any action. If you are 45 or older and at average risk, ask your healthcare provider about screening for colon cancer with the Cologuard test. You can also request a prescription at Cologuard.com.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME credit through MyCares and Michigan State University. The link for the CME is in the show notes. This week, John, you are going to take us through an article about treating alcohol use disorder in people with severe liver disease. So how are you doing tonight?
I'm pretty good. My house is just recovering from gastroenteritis, so it's always kind of fun as a parent with young kids.
I'm very grateful to be talking to you on Zoom right now.
Yeah, there's nothing quite as invigorating. Like a cup of coffee or a cold shower really gets you going, but a child thrown up in your bed at 2 a.m, that's like the ultimate, let's get going.
Right. The ultimate adrenaline rush that really wakes you up.
Just panic.
Oh my gosh. Yeah.
How about you? What's been?
Oh, I'm good. I was going to say my kids are too old for that to throw up in our bed, but sometimes we hear the dog puking in the middle of the night. That's sort of the same. You kind of hear that hacking noise. And you just hope
they're going to... Your oldest is going to senior beach week, right? Though, so
yes.
maybe not too old.
If there's middle of the night vomiting, I don't need to know about it. It's happening in Ocean City.
Okay.
Oh my gosh. So, John, is there anything you want to share with our audience about addiction in the news?
I actually don't have anything for this episode. How about you? I know you're probably more prepared than me.
So, I guess one thing that, I noted was that it is the end of an era because Perdue Pharma is no more. So we're recording this first week of June. So as of about 3 days ago, Friday, May 29th, Perdue Pharma officially ceased operations and completed its bankruptcy filing that started in 2019. It's been a long time coming. Now that all the lawsuits are working their way through the courts, once everything's been settled, what will be left is a single nonprofit pharmaceutical company that makes overdose reversal and addiction treatment medications that they plan to sell at or below cost. So Purdue is no more. I think the individual members of the Sackler family will have to pay about $7 billion in settlement money, but they're shielded at this point from individual criminal prosecution. Even though about 1 million people have died from opioid overdose in the last 30 years, and their company definitely launched and facilitated that. Although I can't blame them entirely. So it's interesting. I really think it's the end of an era. So RIP, what do you think, John?
I mean, it is interesting. I feel like this thing has just kind of flipped so much in the past 10 years since I started practice. I don't know. It must have been wild back in the day when you were just giving everyone opioids and thinking it was the right thing to do, and patients loved you for it. And I feel like, I think the last 10, 15 years, a lot of time has been spent undoing a lot of those prescriptions.
Yeah. Yeah, a lot of damage done and but it wasn't just Purdue Pharma. It was a lot of bad actor pill mill doctors who really got in on it. A lot of gullible primary care doctors, I hate to say, but, who just kind of went along with it despite their better judgment. So, yeah, it's interesting.
It is interesting. It takes it takes one doc in a community, right, to really create havoc. I think I've seen this now several times, right? That one person that disrupts.
Well, and we're still feeling the reverberations. I mean, I know for us, we struggle with buprenorphine. availability at the pharmacies. Each pharmacy only has a certain amount that they can get each month. And that's a legacy of these sort of pill mills that were connected to pharmacies who would order, millions of doses of pills out to small communities. And they can no longer do that. Now we have the opposite problem. We don't have enough, especially buprenorphine for the people in the community. But yeah, I mean, it's really, I think it's one of the major changes in our kind of medical lifetime.
Yeah.
But
Hopefully
yeah,
for the better. I mean, the pendulum is swinging. I feel like it's interesting. I always tell the medical students, and even I was at a recent opioid collaboration meeting, and I feel like the answer is never always or never, right? And I feel like the problem is I think the pendulum is swinging a little bit too far in some regards. I mean, there's a number of people that they don't prescribe anything for pain, and I don't know. There's to select indications where it's appropriate.
yeah, I mean, they're risky medicines and it takes some knowledge to prescribe them correctly, but like that's why you go to medical school,
Yep.
All right, you ready to talk about your article?
Yeah. I have a really cool article I thought is from JAMA Network Open. So it's from just February of 2026. It's medications for alcohol use disorder among patients with severe alcohol-related liver disease. So some background here. Alcohol use and alcohol-related liver disease has increased substantially since COVID-19. So we've had a rise again of alcohol-related liver disease. I always feel like, whatever you want to call it, fatty liver disease, and then it was NASH, and now it's called MASLD. It's like fatty liver disease or metabolic liver disease is duking it out with alcoholic liver disease for top transplant indication. And I feel like they keep going back and forth. Nearly 30 million Americans have alcohol use disorder. So that's approximately 17 million people with alcoholic liver disease. Alcoholic liver disease is a leading indication for liver transplant. Currently, the leading cause having surpassed MASLD. And it's kind of a current contributor for U.S. morbidity and mortality. Abstinence is central to treatment with alcoholic liver disease, but patients with moderate to severe alcohol use disorder often require additional support than just telling them to stop. Effective treatment really typically requires a multidisciplinary approach addressing dependence, mental health, and also their lack or social support or need for social support. Medications for alcohol use disorder have been shown to reduce alcohol use, slow alcoholic liver disease progression, and improve survival, although access still remains a major barrier for these medications. Barriers include stigma, underscreening, limited clinician familiarity. And it's interesting. I do feel like the same medications being prescribed for another indication are embraced versus when you're using it for substance use disorder, often kind of shied away from by many clinicians. Despite all these benefits, uptake and utilization of these medications remains extremely low. So only 7.8% of all patients with alcohol use disorder receive any form of treatment, and only 2% receive standard of care, which is incorporating a medication for alcohol use disorder. When you actually look further down to the patients that probably benefit the most, those with liver disease, that's even lower, with some studies showing less than 1% actually having access to medications for alcohol use disorder.
So, John, do you think that's like the provider's fault? Like we don't offer it? Do you think it's patients or culture's fault that they don't seek it out or they don't want it? Like why is this so low?
I think it's a combination of things. I think there definitely is a lack of provider familiarity or wanting to engage. And I hate to be ageist here, but I definitely see a cultural barrier with the older physicians versus the younger. Definitely substance use disorder, diagnosis, treatment, training. It's much more common and much more comfortable of a skill for our younger physicians, mostly because it's just been part of their training. I think that's a big part of it. I think that having access and follow-up become difficult. The question becomes, where do you provide that care? Give credit where credit's due. A really good lecture on this was done at a grand rounds by actually our local transplant center for liver, Hershey Medical Center. And the hepatology department that evaluates and treats transplant actually was providing the service. So integrating into a medical model like that, I think, is really good instead of fragmenting care. And I don't think the medicines are quite the smoking gun that like methadone or buprenorphine is. So I think that sometimes because there's it's not a kind of an answer by itself. I think sometimes patient uptake is a little bit lower.
Yeah. Yeah, I agree. I mean, I offer medications to help people quit drinking whenever I hear that they drink more than I think is healthy, but I rarely do I get people who say, yes, they want that if they haven't approached me for wanting care. But I do see people, I feel like there's been a lot more sort of, I don't know, like social media or chatter about naltrexone, especially targeted naltrexone and alcohol use disorder among younger people. So I've had a bunch of like younger people, like in their early 30s, kind of come and actually request naltrexone.
It's funny in my business school, they like had to watch a TED talk for one of the classes, and that was actually the next TED talk was about Sinclair method. I thought
I
it was
queued
very
it up for
interesting.
you.
Yeah, yeah. No, it just like was like the next one. I was like, oh, that's kind of interesting. Right next to him to hear about operations expansion. Yeah, and I think also, one other layer to that onion is, you think that your patients that benefit the most or have the most to gain or lose, depending on how you look at it, are liver disease patients, and certainly naltrexone probably has the most evidence behind it, and certainly there was concern for that medication with liver disease specifically.
Yeah.
So I think that's another compounding factor. So maybe people think that they're too sick to engage in treatment. So what's the clinical question of this particular trial? Is the use of medications for alcohol use disorder associated with lower long-term mortality among patients with severe alcohol-related liver disease? So a little bit about the study. It's a retrospective single-center cohort study of 1,309 adults with severe alcohol-related liver disease, and they were referred for a liver transplant evaluation at a tertiary care center between 2016 and 2022. The study used EMR data to identify the relationship between medication for alcohol use disorder exposure. They used FDA-approved and off-label agents and all-cause mortality, survival, and transplant likelihood. Inclusion included in the adults, age 18 plus. They had to be referred for a liver transplant evaluation. Alcoholic liver disease had to be identified as the primary cause of liver disease based upon the transplant committee's review of the documentation. Severe alcohol liver disease had to be confirmed through the notes and review of the transplant committee, excluded anyone under age 18, and excluded anyone with alcoholic liver disease not listed as a primary cause of liver disease. Primary outcomes were all-cause mortality, so that was EMR documentation, kind of review how they assess that primary outcome. Other secondary outcomes include survival association with medication for alcohol use disorder use, survival associated with duration of use, survival associated with the number of medications for alcohol use disorder prescribed, the likelihood of undergoing liver transplantation associated with medications for alcohol use disorder, survival among patients without liver transplantation, and liver decompensation and complications identified via ICD-10 codes. They did Kaplan-Meier curves and log-rank testing for regression analysis, and they did try to adjust for socioeconomic and clinical covariates that could possibly confound the picture here. So I guess, what do you think about that so far, Sonya?
I think it's good. I mean, the fact that their major outcomes are mostly like mortality speaks to it being a very high risk population. Like usually our alcohol disease studies, we don't necessarily have mortality as an outcome because that's a rare, it's an unusual occurrence in, our studies over a year or 6 months or something. So obviously high risk of mortality population with, facing liver transplant, severe liver disease. But at that point, I'm just wondering, you said maybe why don't people do this treatment? I wonder if there's like some therapeutic nihilism, like what's the point? We've gone this far. What's the point of trying to treat the alcohol use disorder now?
Sure.
And so really sort of facing that and saying to these patients who are, very high risk of death, what's the point of treating the alcohol use disorder? So I think that's very interesting, and maybe, depending on what we find, might be compelling for people.
Yeah. So is it valid? So there's no really direct conflict of interest with the study funding. So there's no reported industry funding. One author reported serving as Madrigal's speaker bureau. So, Madrigal, they basically make the new drug for Mazdol, resmetirom. So that's really not a direct conflict of interest, right? So it's kind of different cause of liver disease. So Mazdol versus alcohol-related liver disease. It's a large retrospective study of 1,309 patients with severe alcohol-related liver disease referred to a tertiary care center for evaluation of liver transplantation. It's retrospective, so it's not an RCT, which would be our gold standard here. There clearly is a referral selection bias here. I think that typically people being referred to a transplant center twofold. One is they're more severely ill. Second, if someone's actually going for a transplant evaluation, it actually does kind of self-select an engaged population, right? So to actually go for a transplant evaluation, you have to kind of get in a car, drive to the tertiary care center. I think some of my most severe alcoholic patients, they kind of just suffer in silence and just come to the hospital that's local to them with their acute complications and really don't engage in outpatient care whatsoever. The author notes a single tertiary care site might limit results to other tertiary care sites. I'd argue it kind of limits generalizability to kind of the general population as well, since there's a selection bias like we talked about. When you look at kind of like further looking at this kind of like selection bias that they talk about, they did try to statistically adjudicate for medical severity, medical comorbidities. But I will say the population of this study, they just seem different at baseline. When you look at them, 36.7% of participants were on medications for alcohol use disorder at the time of evaluation. And like I said before, the previous study shows 0.4 up to maybe 1% of patients with alcohol liver disease receive medication. So this kind of selects not only like an engaged subgroup, but also kind of an engaged in treatment subgroup. There's a lot of EMR dependent measurement bias. I feel like I hammer on this every time. I think it's because like my other role where we do look at data from the EMR and we like mine it and evaluate it. I really just lost some trust in strictly EMR data. I feel like there's a lot of things that are lost in these in Epic, we have the slicer dicer. If you don't select just the right slice, you're going to miss large sections of your data, even under best circumstances. So there's a little bit of dirtiness to EMR data, even in perfect state.
It's incredible. I was trying to do a report just to see like what kind of services we might need at one of our community hospital emergency rooms, and I looked for like drug overdose as the diagnosis, that would have brought people to the ER. Like in my mind, that seems pretty clear. What did I pull up? Like a bunch of 90-year-olds who accidentally took too much blood pressure medicine and were like dizzy.
Yeah, they're in the street.
I know, right? I'm like, are all these 90-year-olds using fentanyl? No, they're just
metoprolol. They're going hard.
Right, they're going hard on the cardizem.
Another thing is that the clinical indication for the medication for alcohol use disorder was unknown or blinded to the research. So, definitely like naltrexone, acamprosate, disulfiram. I mean, there's very few other indications for that. I should have dug further through the supplemental, but gabapentin was listed. I mean, gabapentin is like vitamin G, right? I feel like it's used for everything. And, even appropriately so, like, God, I see a study for gabapentin for everything, right? It has a statistically significant benefit in alcohol use disorder, neuropathic pain, chronic cough, an adjunct for anxiety. Like those are all like study-based metrics that have been shown to be beneficial, right?
It's restless legs. I just got a super snippy consult from a neurologist telling me I should not be using ropinirole. I should be using gabapentin for restless leg syndrome.
Really? I've gotten the opposite from other people too. So
yeah, get it together, neurology. Figure it out.
That's a sidebar, but the restless leg medications, they actually kind of do make quite a difference for impulse control, right? I think 1 in 10 people meet the criteria for impulse control disorder after starting a dopaminergic agent there. And I have had some people do some pretty uncharacteristic stuff because of their restless leg meds, but this is really off topic now.
Totally off topic, but I've also moved away from them. Gabapentin all the way.
The study did not measure or account for mental health care and non-pharmacological treatment for alcohol use disorder. So that's a possible confounding variable. Certainly I think most patients that do well with alcohol use disorder treatment have some degree of behavioral health component as well. At least I will say that anecdotally. The final 2 years, the study overlapped with COVID-19 pandemic. So, for my slide, who knows what that did, but it probably did something not good to the data. So what are the results here? Any other thoughts about like the validity of this?
No, I think it's pretty good.
Yeah, I really like it. I thought it was a good analysis here. So like we said before, demographics, there was 1,309 patients with severe alcohol-related liver disease. 35.7% received medications for alcohol use disorder. So that's relatively high, not ideal state, clearly, since it's standard of care, but certainly that's better than most. The mean age was 57.1. The patients that received medications, actually, it was a statistically significant difference. They tend to be younger. So younger patients were more likely to receive medications. There were more men than women in this trial. Men are always kind of we're overrepresenting ourselves in alcohol use disorder at 75.6% of the patients were in that group. Actually, most were Hispanic, 45.5%, 26% were white, so a little different. The mean follow-up was 38 months, plus or minus 25. The mean MELD score was 22.6, and it was interestingly, it was higher in the medication for alcohol use disorder group, and that was statistically significant, 25 versus 21.3. Mean hepatic decompensation was higher in the medication for alcohol use disorder group, 1.7 versus 1.5, and that was highly statistically significant. Hepatic encephalopathy was more common in the patients that received medications for alcohol use disorder, 53.5% versus 40.4%, highly statistically significant. Bleeding varices was higher in the medication for alcohol use disorder group, 19.9 versus 12.7%, highly statistically significant. And the Charlson Comorbidity Index was higher in the group that received medication, so 8.4 versus 6.9%, and that was highly statistically significant. So kind of that previous theory that I just gave you was totally did not track here, right? So the totally
Didn't
off.
pan
Right?
out.
So, no, didn't pan out. So I'm just not the case at all. The patients that were on treatment for medication, they were sicker. They were substantially sicker than the patients not receiving treatment. So they were younger and sicker. So that was an interesting point to me.
Well, I mean, I guess it's in some ways, yeah, if you're sicker, you should get more treatment. But like all these people should get treatment.
I mean, they're pretty sick, Sonya. They're going to get a liver transplant. I mean,
Hey, man, you divided them into two groups, sicker and less sicker.
There ain't much more to go there. So the primary outcomes all cause mortality. So medications for alcohol use disorder greater than 3 months was associated with a higher 1-year survival, so 6.6% increase, and an 18.5% 3-year increase in survival. So much more likely to survive if they had medications for alcohol use disorder. When you look at adjusted mortality benefit, they remain significant even after controlling for liver disease, transplant status, comorbidities, and those socio-demographic factors. And that was a hazard ratio of 0.59. For secondary outcomes, longer medication use was not surprisingly associated with lower mortality. So, if you had no medication use, you had a 34.7% mortality rate versus 12.6% in the medication group. When you talk about increasing numbers of medications for alcohol use disorder, actually more meds equaled lower mortality, and that was statistically significant. 0 medications, 34.3% mortality rate. 3 medications, 10% mortality rate. And I thought this was very interesting. They had the number needed to treat for patients with alcohol use disorder with medication. So the number needed to treat with 1 medication for alcohol use disorder was 31, 2 was 12, and 3 was 4. So, that was like huge for me because I'll be honest with you, like I do prescribe a fair number of medicines. It's somewhat rare that I prescribe 2 concurrently, but 3, I don't think I've ever done that before reading this, but it would show here that up to 3 you're getting some benefit, at least in this.
Well, the other thing that strikes me is other than the long-acting injectable naltrexone, most of these are like old generic medications, and we've just spent like $1 billion on a liver transplant. And then, he's like $8 a month of, naltrexone or a camprosate or something, for an 18%, increase in 3-year survival. Like, what of all these other interventions gives you that survival benefit?
Yeah,
Probably not many of them,
Those are way higher than blood pressure control, statins for cholesterol prevention. I mean, this is pretty. I mean, number you get treated for is ridiculous, right? I feel like that's amazing. Well, I can't even think of something that's number needed to treat it for.
Right. I mean, it's a little not quite as clean because this wasn't like, this isn't like randomized controlled trial.
Yeah,
so these are people who you chose 3 medicines for. But still, but that's a huge learning point in this article. I also don't double up my medications for alcohol use disorder. I tend to just
triple.
Or triple. I definitely don't do that. Like I start one, and if it doesn't work, I stop it and do a different one.
Yeah, that's what I've kind of done to date. Well, that shows always something to learn. That's why these articles are fun, right?
Yeah, totally.
So patients receiving medications were more likely to undergo liver transplantation. So any medication, 39.2% versus no medication, 17.2%, and that was statistically significant. Liver transplant was highest with greater than 3 months of medication use or medication for alcohol use disorder use. So it was almost 50% in that case. Survival benefit persisted even when patients didn't get a liver transplant. So you could be sick enough to be evaluated for a liver transplant, but just being on the medications and being treated would decreases your chances of mortality substantially here. Mortality reductions demonstrate significant dose response relationships, predominantly with greater number of medications and longer duration of treatment. So, it's interesting. I'm not a big fan of polypharmacy for behavioral health meds, but certainly this might be a compelling indication where it might be a reasonable alternative. So, will the results help me in patient care? I mean, Sonya, what do you think?
Oh, I mean, totally. I'm not a transplant center. We don't actually do transplants at St. Max's. So I have patients who are going to need a transplant, so I'm not directly working with this population really, but I feel like I can extrapolate to other people with alcohol associated liver disease. And it definitely, I'll be using it, encouraging it. I'm actually increasing my teaching on how to treat alcohol use disorder for next year for our residents, really trying to promote this. This paper just emphasizes how important it is.
Yeah, I mean, as addiction med and family medicine, and actually inpatient, I think I encounter these patients the most, the severe liver disease, because the truth is, I often don't get them following up that often in the office. And it's also where I encounter my partner's patients that kind of fall into this group. And I think that this is a learning curve for me. I think that the big thing here is I think we always knew that treatment was good. I do think I might be guilty. I'm not going to say might. I know who I am. I probably have been guilty in the past of thinking that someone's too sick, especially with their end stage cirrhosis. You don't think they're even a transplant candidate, that they wouldn't tolerate one of these medications, especially when they're developing encephalopathy. Some of the meds gabapentin, baclofen, they're very sedating. Acamprosate, they're very sedating. I feel like I've kind of shied away from intensifying those, especially with my encephalopathy patients. But this study would show maybe that I was wrong to think that way. I think that I probably should be intensifying treatment. And I think the big learning point for me in this trial is that not only is it helpful, but I should be going up to 3 meds with increasing evidence that longer duration and adding more to therapy is beneficial.
Totally. It's making me remember our very, very first episode from a few years ago about smoking cessation in patients after diagnosis of lung cancer. And, we both, I think, used to be like, well, it's at this point, why bother quitting smoking? And we showed just a huge increase in mortality in that paper. And it's sort of the same thing. Like, it is, the sicker you are, actually, the more benefit you get from some of these interventions.
Yeah.
So I thought it was a great paper.
I liked it a lot. Yeah.
Definitely changed my practice. So we did get a little bit of talk back I wanted to share. So John, you shared an article in episode 76 about injectable buprenorphine in pregnancy. And the authors of that paper did send us an email, and they said it seems like we're the kind of people who are open to feedback. And so they wanted to give us some feedback. And we truly are. I hope we didn't say anything too stupid in that episode. But no, for all our listeners, we are very open to feedback. And actually, it's a rare thing to get feedback as an attending. Like, I kind of wish I could go back and have someone observe me for a day, like seeing patients, and give me some feedback. It's not something that happens too often. You're kind of on your own once you're out in practice. So we appreciate it. And if anyone else has feedback for us, please send it in. So let's get to their feedback. Again, this was an article about injectable buprenorphine in pregnancy. So one thing we did, I mentioned about methadone being sort of standard of care for opioid use disorder in pregnancy, but in fact, that is not true. Buprenorphine is equally effective, and both could be considered gold standard. Although neither is explicitly approved for use in pregnancy, they're both considered standard of care, and patients can choose either one they want. So that was a piece of feedback. And then, John, you were wondered about them following up the infants long term. I think the study was like 12 months. And they said they actually do have a sub-study following infants up to 24 months, hopefully coming out soon, delayed by ... COVID, like so many things. So that was feedback number 2. So hopefully we'll get to see that paper when it comes out. Feedback number 3, there was a higher adverse event rate during pregnancy in the extended release buprenorphine group. Was for the medication related adverse events. but there wasn't a statistically significant difference in the number of adverse events, regardless of whether they were related to medicine or not, between the two groups. And they did not report injection site reactions as adverse events. They were other medication reactions. So overall, there was the same number of adverse events, but there were slightly more adverse events related to the medication in the injectable buprenorphine group. So that's that. And final point, well, I don't know. What do you think so far of these three?
I mean, they're all valid. And definitely good feedback, right? I'm happy to hear about the trial going forward. I think the gold standard one, I think, most of us use probably buprenorphine at this point. I think the gold standard comment was really more so just that historically methadone has kind of been considered the standard of care. But certainly, I'd say in today's era, it doesn't mean that it's the best. It certainly is not the best. In some regards, it lags behind buprenorphine, actually. But it definitely is kind of what's considered the old textbook answer.
Yeah, for sure. And then the final thing, we talked a little bit about the time to peak after different injections. And it's faster in the monthly injection versus the weekly formulation. And they just said it has to do with the entire composition of the drug, the technology. There's like a fluid crystal in the monthly and something called Atrogel in, one of the other brands monthly. They just have different time to peaks. So the monthly one that was portrayed in this article that we did, the peak is about 10 hours. Which is still a lot slower than if you took it sublingual. So if you're talking about, doing an injection, how long till it hits its peak? It's not just the one compound. I think, what was it that you called it? The NMP.
Yeah.
It's the entire kind of matrix that the meds are in. So we are very grateful for the feedback. I hope that anyone who's listening to us will send us more.
Thanks for it.
So thank you everyone for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in future episodes, send us your comments on social media, email, join our Facebook group. The links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.
Ryan Reynolds here from Mint Mobile with a message for everyone paying big wireless way too much. Please, for the love of everything good in this world, stop. With Mint, you can get premium wireless for just $15 a month. Of course, if you enjoy overpaying, no judgments, but that's weird. Okay, one judgment. Anyway, give it a try at mintmobile.com/switch.
Upfront payment of $45 for 3-month plan, equivalent to $15 per month required. Intro rate first 3 months only, then full price plan options available. Taxes and fees extra. See full terms at mintmobile.com.